So lower limb trauma, the first thing that we are going to discuss is the pelvic fracture. Pelvic fracture is when it happens when there is a high volume of high velocity trauma. So here the main issue is hypovolemic shock. So we have to save the life of the patient. So what you have to do, you have to control the bleeding. How do you control the bleeding? The first step that you have to do is to pressure and to give pelvic binder. So before that, let's see the types of pelvic fracture. The first one is when there is an anteroposterior force, the pelvis will open like a book. This is known as an open book fracture. Then there is a crescent fracture. Crescent fracture is a fracture in the posterior iliac wing which will extend into the sacroiliac joint, a crescent fracture. Then you're having windswept fracture. Windswept fracture is crescent fracture plus open book. That is when you have a lateral plus an AP compression. So AP compression will give you an open book, and then you have a lateral compression, you have a crescent type fracture, which is a fracture of the iliac bone which is extending into the sacroiliac joint. Then you're having a vertical shear. When a vertical shear comes, the type of fracture that you have is known as a Malgene fracture. In Malgene fracture, there is disruption of the ipsilateral, that's the same side, superior and inferior pubic rami, and there is sacroiliac joint. So say for example, this is the sacrum, right? This is the sacroiliac joint. So there is disruption of the sacroiliac joint, and then there is disruption of the superior and inferior pubic rami. I know my drawing just sucks, but you have to bear with me in this. So this is the pubic symphysis. So there is disruption of this plus superior plus inferior pubic rami. This is known as the Malgene fracture, very important. Then you have the Durevant's fracture. Durevant's fracture is when you have a fracture of the iliac wing. It is known as Durvereni fracture. Jumbo's fracture is a transverse fracture of the sacrum. Straddle fracture again is the fracture of the bilateral superior and inferior pubic rami. This is straddle fracture, such that this box just comes out. Then you're having the management. As I told you, there can be loss of around 1.5 to 2 liters of blood can be lost in one go, because this is a highly cancellous wound, right? So cancellous means there's going to be high blood vessels into it. There's a big pelvic venous plexus. So the first thing that you have to do is you have to give a tamponade and compress. Let's turn to the next page. So the first thing that you have to do is you have to apply a pelvic bandage or pelvic binder and give crystalloids. That is the immediate management. Then what you have to do is you can put a pelvic external fixator. The thing that you see in the center in the third image, it is we are not putting the fixator on the pubis. It's just we are tightening it there. We are not drilling the pubis in this. That's what I thought initially, but that's not what's happening. And blood transfusion. Then there are 3 hip dislocations. I told you whether it is leg or whether it is arm. If it is anterior, it is aber. It is posterior, it is other. Okay, now Abu is a very tall person, so there is apparent lengthening of the wound. Other means there is apparent shortening of the wound. Okay, so Scarpa's triangle, you will feel the femoral head in anterior dislocation, and then in central dislocation you will see shortening again. Okay, central dislocation, shortening again, and then you will have mild, you will be able to palpate the femoral head per rectally. Now go to the next page. Then you have the neck of the femur fracture. Neck of the femur fracture, there is mild extension. So whenever the text question says mild extension, we are thinking about neck of femur fracture. Okay, neck of femur fracture. Here you having Garden classification. Previously we had seen a Garland classification for the supracondyle of the humerus fracture. Now you're having a Garden classification 1, 2, 3 and 4. Remember, 2 is undisplaced. 3 is partially displaced, 4 is completely displaced. So Garden has 1 to 4 in it. Okay, now just to go back for the supracondylar humeral fracture, we have Garland classification. Okay, Garland classification. In Garland classification, page number 14, you see type 1, 2, 3, right? 1, 2 and 3. Here you're having 1, 2, 3 and 4. So let's go from the back. Here it is completely displaced. Here it is partially displaced. This is undisplaced. Here this is 4 is completely displaced, partially displaced, undisplaced. So what is 1? 1 is incomplete vagal valgus impacted fracture. That's how you learn it, okay? Incomplete valgal impacted fracture. Then you have one more fracture classification that is known as the Powell's classification, which is the horizontal line and the fracture line. The horizontal line and the fracture line will take the ankle. There is again for this going to be 1, 2 and 3. So 1 is less than 30 degree, 2 is 30 to 50, and then 3 is more than 50 degree. Okay, now you're having the treatment protocol for neck of femur fracture. All you have to see if there is osteoarthritis. If there is osteoarthritis, then you have to do total hip replacement. Then without osteoarthritis, if the patient is more than 65 years, then you have to do hemiarthroplasty. If the patient is less than 65 years, then you can do screw fixation. So it's less than 65 years without arthritis, without osteoarthritis, screw fixation, the best one, right? And then the complication, they can be non-union avascular necrosis of the femur. Then next thing that you have is the intertrochanteric fracture. Intertrochanteric fracture, there will be severe extension, external rotation, okay? So when they tell you mild external rotation, what do you think about? You think about neck of femur fracture, okay? Mild external rotation, think of neck of femur fracture. But when they tell you there is severe external rotation, I want you to think about intertrochanteric fracture, right? So that's how you approach the question. Severe external rotation of the hip, and there is going to be severe pain. Here there is going to be tenderness in the Scarpa's triangle. Here, Scarpa's triangle, tenderness. Here you are having very severe pain, okay? A very severe pain. So here the complication is malunion, not non-union. Here the treatment of choice for this, which was the previous NEET question, is dynamic hip screw, or it can be proximal femoral nailing. Next, having the shaft of the femur fracture, what you have to do is you have to apply the Thomas splint. If you don't apply the Thomas splint, there is increased risk of bleeding and fat embolism, and you have to do external fixation only in case you are dealing with a open fracture, okay? And then fat embolism, there is a triad, classical triad of fat embolism, which is involving the respiratory symptoms, cerebral symptoms, and petechial rashes. Cerebral symptoms as in confusion, delirium, dyspnea, tachypnea for respiratory symptoms. Okay, so it usually happens 24 to 72 hours after the fracture. You will have what is known as the fat embolism. Page number, darling, page number is 42. Okay, so fat embolism, you're having, it will occur after 24 to 72 hours after the onset, after the injury. And you have criteria which is known as the Gertz criteria. So fat embolism, usually it happens following a trauma, or it can be liposuction, acute pancreatitis, sickle cell disease, burns. All of this can be a cause. So how do you prevent it? Applying Thomas splint and hydration. How do you manage it? You can just give oxygen, you can do mechanical ventilation, and there is something that you can do for fat embolism, which is human albumin infusion. So very important, fat embolism, you can give human albumin infusion. So how does human albumin infusion help? So albumin will bind to the fat lobules and it will promote its excretion. This is how human albumin infusion will help. Next is fracture of patella. Fracture of patella, one of the fracture is undisplaced, where a cylindrical or tube cast. If it is, displaced, then you can do tension band wiring. If it is comminuted, patelectomy. So the three management for fracture of patella: undisplaced, displaced, comminuted. Displaced, tension band wiring; comminuted, patelectomy. Bipartite patella is because there is, synchondrosis. The two bones have, ossified via synchondrosis. It's a normal finding, and it will be seen in bilateral. Same, both the legs you will see the same change. That is because it is ossifying by synchondrosis. Okay, synchondrosis. The next thing is about the fracture of shaft of tibia. Here you are using patellar tendon bearing cast, and then you are putting intramedullary nailing. If it is open, then the most common bone to undergo non-union here is actually tibia. Okay, most common bone to undergo non-union is tibia. That is the junction of middle 1/3 and distal 1/3. Okay, and then you're having certain fractures. One is Mansour fracture, which is medial malleolus and proximal fibula. Proximal fibula and medial malleolus. Pilon fracture is intra-articular fracture of the distal tibia. Bumba's fracture is fracture of the lateral condyle of the tibia. Okay, Then again, POTS bimalleolar, cotton trimalleolar, runner, stress fracture of the distal tibia. Then, yeah, that's all. So, go to the next page. Fracture of the calcaneum is known as Lovers, Don Juan, or Casanova fracture. Here, Bohr's ankle is baby, becomes smaller, and Gisni's ankle becomes grandpa. So, it's becoming greater. So, the treatment, if it is not displaced, you will put cast. If it is displaced, you can put late. Then having talus fracture, if it is a neck of talus, it is aviator astragalus. If it is the lateral fracture, it is known as a snowboarder's fracture. The classification that you use in talus fracture is Hawkins classification. And for this, if it is displaced, screw. If it is undisplaced, cast. So for calcaneum and talus, if it is displaced, screw. And if it is undisplaced, BK cast for talus, cast for calcaneum. If it is displaced, for calcaneum, we will put open reduction, internal fixation with plating. Talus, we put screw fixation. And then Hawkins sign is the sign of revascularization and viability of the talus. That is, you see an area of radiolucency in the subchondral bone of the talus. Fifth metatarsal fracture can be classified as pseudojones, Jones, and dancers. Pseudojones is between the tarso-metatarsal. If you see a line, that is pseudojones. If it is intermetatarsal, it is Jones. Intermetatarsal is Jones. Stress fracture is that you see in the fifth metatarsal alone. So Jones fracture is associated with non-union because it is in the watershed area. Classifying the open fractures, you having Guslow-Anderson classification, which classified the open fractures as grade 1, 2 and 3. 1 means it is less than 1 centimeter, 2 means it is 1 to 10 centimeter, 3 means it is more than 10 centimeter, 3 is again classified as A, B and C, where A means it is periosteum is not involved. Here there is periosteal stripping. C means it is vascular injury. Okay, so periosteal stripping implies you have to use a skin graft or you have to use a graft cover. And then whenever you are putting the external fixator, you have to put it away from the zone of contamination. Now there are two scores that we need to know. One is the MES score. So MES score, remember a C. Okay, so this is a score that is used to determine whether we have to go ahead with an amputation or we have to save the foot. So if the score is more than 7, you would amputate. If it is less than 7, you would save the foot. Okay, this is amputate. So what is this ASI? What are the criterions that is involved in ASI? That is age, shock, injury and ischemia. Okay, injury as in low, medium, high energy injury. Ischemia means whether there is limb ischemia involved, like pulselessness, paralyzed or anything. Shock means that the patient is in shock. Age means whether they are above 50, less than 30 and all that. So this is all you have to remember if the MES score is more than 7. And then one more score that we have learned in terms of pathological fracture is known as the Merrill's criteria. Merrill's criteria means if it is more than 8, implies that you will have to do a prophylactic surgery. If it is less than 8, you don't have to do it. So Merrill's criteria, what did we have? It is site, size, lesion and pain. Site, size, lesion and pain. These are the things that we included in the Merrill's criteria. If it is more than 8, you have to do prophylactic surgery. Then another important thing that you have to learn, when there is supracondylar fracture of the humerus, it involves the median nerve and anterior interosseous nerve. Now when there is any fracture that is involving the radius, there is involvement of the posterior interosseous nerve. So for example, if there is fracture of radius, Montagiar, radial head dislocation, you will have to see for pin. Supracondylar fracture, you will have to see for the N. Next is non-union. So there are definitions for non-union and there is delayed union. Non-union means there is no union beyond 9 months of fracture. Delayed union means no union beyond 6 months of fracture. Okay, so common fracture malunions. And then there is hypertrophic malunion and atrophic malunion. Hypertrophic malunion, just fix it properly so that there won't be much of callus. Atrophic malunion, you have to put a bone graft in the middle. Then you will see the tumors of the bone. First introduction, osteosarcoma is having bimodal age distribution from 10 to 20 years and with 40 to 60 years. Okay, this is osteosarcoma has bimodal age distribution, and then you have to remember that giant cell tumor and coccolocoblastoma, as I always call it, instead of chondroblastoma, is affecting the epiphysis. Diaphysis tumors which affect the diaphysis is Adolf, okay, ADOLFE, Adolf, okay, Adolf in the sense adamantioma, adamantioma, osteoid osteoma, lymphoma, fibrous dysplasia, Ewing sarcoma. Everything else is affecting the metaphysis. So first let's start with osteochondroma. Osteochondroma means, all you have to remember is there is less than 1% risk of developing chondrosarcoma. That's it. Then hereditary multiple exostosis is associated with X gene mutation. It is autosomal dominant and the patient will have short stature. So here in X gene mutation there is 5 to 10% risk of developing cancer. Next is osteoid osteoma. Osteoid osteoma, the pain is relieved by NSAIDs. You will have a nidus. Here the investigation of choice is CT scan. The treatment of choice is radiofrequency ablation. Okay, then it is enchondroma. Enchondroma, you have to remember, it is known as multiple enchondromas, is known as Olier's disease, is affecting the hands, metaphysis of the bones of your hand. Here risk of a malignancy which is chondrosarcoma. Here also chondrosarcoma risk of malignancy is there. So here the treatment of choice is curettage and bone graft. Curettage and bone graft. Okay. Next is chondroblastoma or coccolocoblastoma. Why do I call it coccolocoblastoma? Because the biopsy has chicken wire and cobblestone arrangement of the chondroblast, and it's also known as the Codman's tumor. Codman's triangle is seen in osteosarcoma, but Codman's tumor is chondroblastoma. There is 1% risk of metastasis. Here also the treatment of choice is curettage and bone graft. Again, next thing that you're having is GCT, that is giant cell tumor and osteoclastoma. Here there is 3% risk. So chondroblastoma, 1% risk of lung mets. Here there is 3% risk of benign mets to the lung at shell crackling film, and then so bubble appearance. You have to do extended curettage. Treatment of choice here is extended curettage plus denosumab. Okay. The next is hemangioma. Hemangioma, there is no treatment. It is having Pulka dot sign in CT. So investigation of choice is CT. And in X-ray, what do I see? I see chordroid and jail bar appearance is what I see in X-ray. It's mostly affecting the vertebral body. Treatment of choice is no treatment. Next is simple bone cyst. If it is symptomatic, only then you treat with aspiration and injection of steroids. Next is a neurosemal bone cyst. Here we have to do extended curettage plus graft. Okay. So giant cell tumor, we just did extended curettage and denosumab. Okay. So ABC, we have to do extended curettage and graft. Okay. And then you're having fibrous dysplasia. Fibrous dysplasia is associated with a gene mutation. What is a gene mutation? This is GS alpha protein mutation. Here, asymptomatic, just do observation. If there is pain, then give bisphosphonates. And there is 1% risk of osteosarcoma. So far, what all we saw? So far, we have seen the risk of malignancy only for chondrosarcoma. That is for two things, right? Now here for the first time you're saying osteosarcoma's risk is seen associated 1% with fibrous dysplasia. So osteosarcoma is a very big tumor. It is associated with Paget's disease. It is associated with fibrous dysplasia. It is associated with radiation to the bone, radiation exposure. Two syndromes that you need to know: McCune-Albright syndrome and Mazebraut syndrome. Both are associated with fibrous dysplasia. McCune-Albright is associated with precocious puberty and Cafe-Ole. Next, Mazebraut syndrome is with intramuscular myxomas. So now we'll see, we'll see the malignant tumors of the kidney. Alright? Not the kidney, I mean the bone. So these were all benign tumors. Now we'll see the malignant tumors. When it comes to malignant tumor, you're having osteosarcoma. So here you will see Codman's triangle. So again, I've shown you Codman's tumor is chondroblastoma. Codman's triangle is, what is Codman's triangle? Codman's triangle is seen in osteosarcoma, and you have sunburst appearance. Osteosarcoma, the treatment of choice is surgery plus chemo. The chemo regimen you have is T10 regimen and MAP regimen. This is the most radio-resistant tumor. Next is chondrosarcoma. Chondrosarcoma is mostly seen in 40 to 60 years. Okay, and then here it is mostly affecting the pelvis. So the pelvis will have a radiolucent mass and popcorn classification. Alright, calcification. Here the treatment of choice is just excision alone. Okay, just excise it. Okay, so now excision alone. So chondrosarcoma is seen in 40 to 60 years. So the next tumor that you have to do is Ewing sarcoma, which is seen between 5 to 20 years, 1122 mutation, translocation, EWS, F1, F11, and then it will have MIC2 or CD99 positive. You will also see pseudo rosettes. So pure rosette means there is nothing in the center. If there is something in the center, then it is known as pseudo rosette. Here the treatment of choice again is surgery plus chemo. Although Ewing sarcoma is the most radiosensitive tumor, we do not give radiation because there is risk of development of osteosarcoma. Ewing sarcoma, if you give radiation, it will develop into osteosarcoma. So it's more serious. So we'll treat it with surgery and chemo. Next, you're having is adamantioma. Adamantioma is a low-grade malignant tumor. It is seen in the diaphysis. So here also the treatment of choice. It's low-grade tumor. Just do surgery. You're done. So similarly, chondrosarcoma also low-grade tumor. Just do surgery. So whenever you had two high-grade tumor, osteosarcoma and Ewing sarcoma, you did surgery plus chemo, right? So the next is, you have to know that the primary mets to the bone is most commonly from the breast. For in males, it's mostly from the prostate. In a child, it is from neuroblastoma. The most common malignancy of the bone, it is metastasis. The most common bone involved is spine. When it comes to metastasis, mostly the thoracic spine. Alright. Now there is one aminoblastoma is affecting the mandible. Alright, and the one more thing that you need to know is about the genetics of the tumor. One new thing, that is X18 to 18 translocation is seen in synovial sarcoma. It's a misnomer actually. Synovial sarcoma is not bone tumor. It's a soft tissue tumor of the foot. Okay, I don't know who named it, but it's a soft tissue tumor of foot. So that is all about bone tumors.